Dr. Berenson, are you ready?
I am ready if you can hear me. Yes.
Yes, sir.
Okay, so you're going to also do my slides. I appreciate it. So if we could move on to the next slide, please. So what I'm going to do briefly is consider the changes and expectations of high-quality primary care since the 96 report. Even though it's not directly related to policy, these have implications for where we need to focus our policy. And then I'm going to spend a good part of the presentation talking about workforce payment and quality measurement. Next slide. So let's stipulate that relatively more primary care is associated with higher quality and lower costs. There's now a growing body of literature that strongly supports that proposition, so I don't need to argue that here. But the point I want to make is there's also been recent work by Elizabeth Bradley and Lauren Taylor, and beginning to be reinforced and supported by other researchers that finds that health systems that provide what's happening to my slides. That health systems that provide a much broader commitment to providing social services and less on healthcare is associated with higher quality and lower costs, just like primary care is. So my point is that we absolutely need to increase the share of primary care, the share that primary care gets of healthcare dollars, but that might not result in a major absolute increase in remuneration. It's about allocation. And again, there's been reference to Rhode Island. Delaware is now moving in that direction. It's a redistribution. It's not a dramatic increase in primary care, although I think a modest increase is absolutely necessary. Next slide, please. So primary care is evolving, and here the point I want to make is I took a definition from the 96 report and emphasized that the expectation is that primary care would be accountable for addressing a large majority of personal health care needs. And I think, in fact, that's not the case. It probably wasn't the case then, and it certainly should not be an expectation in any new definition of primary care. As you've heard, current estimates are that primary care represents about 5 to 7% of total commercial insurance. In Medicare, it's even less. In work that I've done with my data, it's only about 2.5% of Medicare spending and even less than 20% of spending in the Medicare physician fee schedule. In short, primary care does not directly address a large majority of personal health care needs, and as discussed next, should not now be expected, and I will argue really doesn't indirectly affect all of that care. Next slide, please. So from 96, the Barbara Starfield 4 Cs was prominent as the as sort of the attributes of high quality primary care, which I've repeated there. And what I'm going to argue in the next few slides is that primary care's commitment to the first 3 of these is waning, while the range of coordination responsibilities is growing dramatically, and that a series of other responsibilities increasingly characterize high-quality primary care. And here I'd say there's people mean different things by comprehensiveness. What I'm going to argue is that clinical comprehensiveness is declining, but that practices can provide a comprehensive set of other services, many of which I sort of outlined in the previous presentation. Next slide, please. So there's no time to go through this in any detail. I saw a pre-publication copy of a book by Ken Terry, and one of the chapters was Primary Care on the Ropes. And he has a hypothetical that one of his first, it actually led the chapter on primary care on the ropes. An intern is describing how he, in this case a he, would have been able to manage a patient in the office and not to have them go to the ER and ultimately have unnecessary surgery. And I read this case, and maybe later in the day you'll have a chance to actually read it. The point I'm making here is I don't believe that I think only about 1 out of 10 primary care physicians today would have done what this physician did and managed this patient in the primary care practice rather than just sending them to the ER. Indeed, I suspect this physician is a dinosaur who will soon be extinct. Next slide, please. So what's been happening with referrals? Another sort of source of evidence about what's happening in the comprehensiveness. This study by Barnett, Song, and Landon in the Archives of Internal Medicine demonstrated a doubling in referrals from 1999 to 2009, similar increase for primary care alone. And I've been in touch with one of the authors, and they are continuing this analysis and now find that the referral rate is in the 13 to 16% range in the last few years. So almost a tripling in 15 years. Also, one of the points that I think is important for the committee to keep in mind is that there is a lot of heterogeneity in primary care. In this one study, which is now 2 decades old, there was a referral rate of less than 1%. I don't know who that physician was. He's some kind of super physician, to just about 70% of patients referred in a year. So there is great heterogeneity. Next slide, please. And there have been, the authors of that study, as well as some other papers, have suggested reasons for the rise in these referrals, including knowledge gaps, time pressures, defensive medicine, but in this 15-year period, malpractice has not been much of a problem. Patient preferences. What doesn't get a lot of attention is that we have moved from what was then a pretty dominant method of gatekeepers and HMOs, where physicians had financial incentives to not refer, to more of a PPO platform where there generally are no penalties. And then finally, the specialty orientation of medical school and graduate medical education. I raise these to just discuss, for purposes of what do we do in policy, is to try to address some of these problems. Some of them might be immutable, like the knowledge gaps for specific disease entities. Next slide, please. So first contact and continuity, I would argue, has also declined significantly. There are various factors that lead primary care practitioners to no longer see their patients in inpatient or post-acute care facilities, again with substantial variation. Again, in data that I have been working with, family practice physicians receive only 12.9% of their revenues from inpatient or observation stay visits, whereas internists, it was 40.6%. But I suspect, and here I don't have the data, that there's a bimodal curve for internists, that many also don't go to the hospital and see their patients. And then there are some internists who predominantly do hospital-based medicine. And that would probably include some hospitalists. But my overall point is that primary care physicians don't follow their patients into the hospital. It's just become sort of accepted. And another point I would make, and this I find correctable and should be correctable, and in my primary care practice, it was an essential responsibility of our practice to be involved with care of patients in the emergency room. We often called ahead to tell the ER doc that the patient was coming, what we knew about them, why they were coming. From what I hear anecdotally, that rarely happens anymore. And indeed, communicating with the ER is not an expectation of the patient-centered medical home. And as a result, I think there's many unnecessary admissions because there's no comfortable home that the ER doc can send the patient to, where they know that somebody's on the other end who will care for them and knows about what happened in the ER. Next, please. A recent study talked about outcomes related to primary care and found that the receipt of primary care was associated with more high-value care, somewhat more low-value care, and better respondent access and experience. That's generally a pretty positive finding. It did worse than specialty care for heart failure and pulmonary disease, which some would consider sort of core activities that a primary care physician should be expert in. And interestingly, about a quarter of the adults report not even having a primary care practice, and 2/3 of these did have private insurance. So it is consistent with the earlier discussion that that patients often get their care outside of their primary care outside of primary care practices. Next, please. A commentary on these findings, Alan Gorel, who's a Harvard professor, internist, and sort of the author of sort of the basic Bible of primary care, clinical Bible. To be sure, the excellent patient experience performance is likely to reflect considerable physician effort, but these results suggest primary care physicians are spending most of their time arranging prevention, performing screening, and offering counseling, while their physician-level diagnostic and management skills, could you go back, please? Or go to where I'm directing. Management skills seem to be unused and might be atrophying. I share this concern, but I think he seriously discounts the many other things that primary care practitioners are doing now beyond prevention, screening, and counseling. In short, clinical comprehensiveness is in decline, but comprehensiveness on a range of other activities is now a foundation of primary care. Next slide. And this supports the case that primary care physicians see more complex patients, primary care practices. I don't want to be so physician-centric. Primary care practices see more complex patients as defined by the number of diagnoses and the number of medications. So the point is here that it is not just prevention. It is not just screening and counseling, that there is a major coordination role that primary care practices are providing. Next, please. So we clearly don't have time to go through all of this. This is my set of expectations that we now have for quality primary care practices. And I just, for purposes of this presentation, I just want to talk about a couple of them. The first one is making accurate diagnoses and referring when it's outside of their expertise. And I'd refer to the IOM, Improving Diagnosis in Healthcare. I was a panel member. We still have an ongoing significant problem of misdiagnosis and failure to diagnose. And it seems to me all physicians need to improve in this area, including primary care. I think, in fact, this is the third bullet, primary care physicians actually are looked to manage a number of high prevalence, what I'd call primary care-based chronic conditions. Hypertension, diabetes, dementia should be managed in a primary care practice. And here, I would argue that they should be expert at caring for patients with affective disorders, including depression, anxiety, even though many of them don't have time or interest in doing this at this moment. Other activities, other expectations. One that I would also say doesn't get much attention is to be responsible for chronic care drug management of patients with multiple chronic conditions who then are on 10 or 12 or 15 drugs. Primary care physicians should be as expert as anybody in dealing with drug complications, drug symptoms that turn out to be related to drug interactions, etc. My point here is to not go through all of these and make a case as to why these are core activities, but simply say that the primary care practice has changed dramatically, I would argue, since 1996, when it was focused mostly on more straightforward clinical problems. lots of these activities are about coordination and complexity, and not about comprehensiveness and continuity. Next, please. So now when I get to the policy implications of all of this, just briefly to say that in the Affordable Care Act, there was a healthcare workforce commission established. It never got an appropriation. It never functioned. The people got appointed to it, got their diplomas from it, and they never had a meeting. We need it as much now, if not more now, than even when this passed 10 years ago. And this is just a summary of what its expectations were. Next slide, please. Because the workforce data shows that there are some significant problems that need to be addressed. We have a lower patient practicing physician to population ratio than other countries. We're near the bottom in the OECD data. We have too many specialists to primary care in the U.S. It's 2 to 1 in most countries. It's approaching 1 to 1. I'm sorry, it's approaching 2 to 1 in the U.S. It's about 1 to 1 in other OECD countries, although there are some definitional issues here. The fourth slide, between 2005 and 2015, the number of jobs for primary care physicians grew 8%, while jobs for specialists grew 48%. With even including PA and nurse practitioner growth, primary care practitioner jobs grew only 17% in that decade. So we still have a maldistribution, and it's increasing, not decreasing. And indeed, by one account, I realized I didn't remember who it was. I now realize it was a recent MedPAC report. There are only 2,500 geriatricians to care for nearly 70 million Medicare beneficiaries. So there is remaining and increasing a workforce problem. Next. And here are some of the issues that have been identified, and I'm not going to go through them. It is what this commission should deal with, and if we don't have a commission, it's what other policy levers need to be used to try to address at least some of these, such as the relatively low remuneration. Unnecessary hassles of practice that could be dramatically improved, et cetera. Next slide. So just a few points about payment. I spend most of my time thinking about payment. I'm a contrarian about volume to value. In Europe, fee-for-service is generally referred to as pay for activity. It's not called pay for volume. It's less pejorative. Many European countries actually paid hospitals on budgets and found that the hospitals took the money and didn't provide a lot of services, so they moved to DRGs because they wanted to reward activity. One could make the same case that some fee-for-service payment is actually desirable, and I would argue that all payment models are designed and implemented to provide more or less value. But they all have inherent strengths and weaknesses. But improvements to the Medicare physician fee schedule, mostly with new codes, the Care Transition Code, the Chronic Care Management Code, have improved value more than APMs in recent years. It should not be ignored as a source of value, the physician fee schedule. And indeed, some of the most promising primary care payment models are hybrids of fee-for-service and per person per month case management payments, for example, CPC Plus. However, Bob, having said that, a lot of the...
Bob, I'm sorry to interrupt. We only have about a minute left. I just wanted to give you a time check.
I have less than a minute to go.
Okay.
Many of the activities that are inherent in current conceptions of primary care are not well supported with fee schedule payments, especially what we all anticipate to be a broad expansion of non-face-to-face communication. I can deal with that in Q's and A's if there's any time. And finally, it is time to revisit resource base as the basis for relative values. Fee levels should also attempt to achieve policy objectives, one of which should be to encourage more time with patients in person or otherwise. And with that, I will not talk about quality measurement other than to say I think the future is in quality improvement activities not quality measurement for consumer choice, but quality improvement to actually improve care. And with that, I will stop.